Okay. Hello, let's move on. Go back to ultrasound. We have heard in the previous lectures how important is an accurate characterization of a given adnexal mass. There is something strange. Okay, it worked. It's my computer.
Okay, in the meantime, it's a good moment to tell you for this afternoon, the people who want to take the MCQ test, it's an open book test. So this means that the simple rules will be printed on your copy. So you don't need to memorize them even, so you can simply try to apply them. So this will help you, hopefully. A second thing is that I see lots of people taking pictures. Please don't use your flashlight because that's not improving the quality of your image. It's better to take an image without flashlight. And we will all ask all speakers whether they agree that the recorded presentations will be put online after the conference. So on the IOTA website, you will find most of the lectures because many people already agreed that the lecture would be online, but not all. So you will find out who will be there.
Okay. And until 2014, logistic regression models and simple rules, risk of malignancy indexes, and scoring system could only differentiate between benign and malignant masses. But we have heard how important it is to, beside this distinction, define whether a given malignant mass is a borderline tumor or a stage 1 tumor or advanced cancer or a metastasis of a primary different cancer. So we will just show you and play with you, show you how it works, the ADNX software, that is the first and only one who can discriminate between all these kind of masses. It is available as an application for smartphone or freely available on the web. So anyone can have it on the same PC on which we write the ultrasound report. And this is the layout with 9 different variables. You have heard from a couple of lectures yesterday that there are 3 variables, 3 clinical variables. One is the age of the patient, one is the type of center in which the ultrasound is performed, and the third is the level of serum CA125. All the other 6 variables are related to the ultrasound features of the mass. So by filling this layout, this report, the software will tell you what is the rate, the percentage of the mass, that masses could be benign or malignant, and among the malignant ones, which is the risk of being borderline, stage 1, stage 2 to 4, or metastasis. And here are some examples that I want to show you. This is a mass with a mixed echogenicity of 75 millimeters in maximum diameter. And here are some clips. Okay. As you see, the content of the cyst is not included in the features of the ADNX model. And I put the clinical features, 36 years old, the patient. It was not an oncology center. Maximum diameter of the lesion, you have seen 75 millimeters. There were no solid portions, no locus, just one locule, of course, no populations, and the patient had a CA125 serum level of 77. If you calculate the risk, it will tell you that the risk of benignity is very high. With 97% of a chance of being benign, and this actually was an endometrioma. This is the calculator on the website that can be copied and
Yes,
and
because
written
some
on the
people
report.
asked if you have it on the app, you cannot copy it into a report or something. Yes, you can copy it from the website and have the calculated risk available
Yep.
for your notes.
Different mess. We know that in clinical practice there are messes which are very difficult, even for expert operators to state whether the mess is benign or malignant, and around 6, 7, 8% of the messes belong to this class, and maybe multilocular messes are one of those. So this is one of those messes difficult to classify, 88 millimeters in maximum diameter, 55 years of age, the patient. There were no papillations and more than 10 locus, no solid portions, no acoustic shadow.
For this, I'm happy that you show a clip, because in some images, it seems that there's solid parts, but if you move along, then you see that there's no solid part, but this is simply the angle, because if the septum, if you're really along with the septum, then it seems that there's some solid part. So artificially, you can make it look like a solid part in a multilocular cyst, but if you have a clip, then you can see that it's completely multilocular, but no solid areas.
And in those cases, even the Doppler analysis doesn't help, because the crossing of the septations may mimic a solid portion, and you can find vessels in it.
Yes, you may see multiple vessels which are in the septa,
Yes.
and then it seems that there's a solid part which is vascularized. So still images are not so good as dynamic information, but that's what we always advocate. Scan the patient yourself and don't just read images. Jeroen.
Luca, can I ask, don't you see shadows appear in this clip?
Maybe yes, you're right.
Oh, well, I just...
Here
Yes.
there are stripy shadows.
Yes, well, moving you see
Yes,
shadows,
it
and in
makes
some
difference,
images
yes.
you don't see any shadows. It's subtle, but you're right. You could include that as shadows. So,
The crossing of the septations may...
But we will see in the room, can this half of the room calculate it with shadows and that half without shadows? And then we will see the outcome, whether it makes a difference.
Without shadows, it tells that almost 20% of the risk of being malignant. And if we assume that the cutoff level for defining a given mass malignant is 10%, so we
You
would
say
consider
yes,
this as malignant.
If you would say shadows, yes, it's only 1.9% risk of a borderline tumor. And the mass is classified as
1.9.
benign.
So if you
So it
take into
changes a lot.
account the classifications, then the risk of malignancy is only 1.8%, and then it's only for borderline tumor, the risk of malignancy. Then there's one question to Professor Vergoten. If we think it's a borderline tumor, should the patient be referred to the gynae-oncologist or to the general gynecologist?
It's a borderline question.
That's a borderline question, yes. Well, I'm a gynecologic oncologist, so I would prefer she's referred to a gynecologic oncologist, I think, yes.
Luckily, there are borderline surgeons that can do.
Okay. They seem to agree.
Okay. Pathology report said that it was a cystadenoma, but with focal areas of mucinous borderline tumor.
Okay.
So we have borderline reports too.
Yes.
Luckily.
So this is a very special case in the way that you know that some borderlines don't look like the borderlines, the serious ones, which are unilocular with papillations. But some borderline tumors, the mucinal intestinal types, are multilocular cysts without any solid part. And then you really struggle to see, is this mucinous cystadenoma or is it borderline tumor?
It would be interesting to know what Gianfranco would say about this. In a case of a big mass like this, cystic mass, my pathologist uses to ask me if I see even one papillary projection or a solid portion, because she struggles to find out that and analyze that without making 100 samples of the normal wall of the cyst. Another case, this was a pregnant patient, young pregnant patient, referred to a gynecological oncology center for a solid mass of 75 millimeters. The whole adnexal mass was solid, and so there were no papillary projections. And it was a solid mass without a cone of shadow. There was no ascites, and CA125 was slightly elevated, but we know that even in pregnancy it can be slightly elevated. Obviously, the patient didn't know of having an adnexal mass before getting pregnant.
So Antonio says Kuchenberg tumor. Any other ideas regarding histology?
Benign or malignant?
Well, based on your app, is it benign or malignant? Who thinks it's benign? Some people
The
say it's
software
benign.
would
Who
say
thinks it's malignant?
high risk of being malignant. And actually, it was a Kuchenberg tumor.
Well done, Antonia. You get a free lunch.
Okay, but Antonia has to guess the next one. It was, yes, it is 100.
It's 46
It
and
is
54. So.
the Italian version, but it sums up being 100.
But it's true, on the website, you see all the malignant together first, and then you see them separately.
Okay. So I want you to guess this one. Lady of 46 years old with an adnexal mass of 75 millimeters, maximum diameter, with 3 papillary projections and a solid portion. I will show you the video clips, and this with color Doppler, testifying that that was a solid portion, because I could find out some blood vessels in it. No ascites, no acoustic shadows, more than 10 locus, yes. Antonio, what do you think about this? High risk of malignancy. I thought about that being a shadow, but I think it's a reverberation. That might look similar, but it is different.
There's clearly shadows to my eye, and there's also some kind of a fluid level.
Fluid ascites, do you mean?
Well, a fluid level, you see some, in this nodular structure, it seems that there's a fluid level. If you see the image on the right, it seems that there's a fluid level which is horizontal, because you hold your probe like this, so it's almost horizontal.
This is a strange mass.
It's a very strange mass, that's
Very
for
unusual.
sure. So we cannot give a proper diagnosis, I think, simply by... But you have a comment?
It seemed to be a struma. Yes, probably.
Who said yes?
Who thinks
Why?
it's a struma?
Why?
Yeah, I think so also. Because there is only it looks slightly like a dermoid unilocular cyst, but within the cyst there is a solid mass which is perfused. And it's usually really happen in the thyroid tissue, and it looks real, it can be a struma.
Do you
Luca,
agree?
what was it?
Well, it was a benign struma ovary.
Well done. Excellent. And this was not prepared, so they didn't know anything about the cases.
Elizabeth, you thought it was a struma too. Okay.
But it's a false positive for the up next, so it's sorry for the
And we know
oncologist,
struma
but
ovaries
this
are
one will
among
be
those
referred to
rare
you.
benign tumors that are false positives to many logistic regression models and so on. So we'll. Yeah.
Okay. So we can go on with some other cases. Okay, here we are. As I show you the clips, this is a small unilocular solid cyst with a solid portion, papillary projection, multiple papillary projection. Oh my God. Okay. Here just the image. Here the color Doppler. I say it's color score 3 with a vessel, a main vessel. This is the 3D, okay? And the ovarian crescent sign. Here we apply the adnex model. May I ask who of you thinks it can be benign, the cyst?
Who thinks it's benign?
Who thinks it's benign?
Nobody?
Who thinks it's borderline? Good. Who thinks it's malignant? Invasive malignant. Okay, we can apply. It was 36 millimeter in diameter. The largest solid part 32. More than 10 locus, no. Papillary projection, yes, more than 3. Acoustic shadow, no. Ascites, no. C1 1 to 5, 9 to 1. We calculate, and here is the result. And it was a borderline tumor. Here I used the app, which you can find on your iPhone again.
So
And the
borderline is
difference in
indicated in
borderline-
yellow here. It was
the
26%.
yellow, yes, right. It's the yellow one from 6.3 to 26.5. Also malignant invasive tumor, but the difference is higher for borderline tumor.
Dorella, may I ask Professor Vergote, he's
Yeah.
here, for the clinician, we are ultrasound examiners, for the clinician, for the oncology surgeons, do you think that is it better to provide these two columns, I mean the pre-risk and the post-risk after ultrasound scan, or is it better or sufficient to provide the diagram Luca showed only with the risk? Because to me, for the surgeon, it's not so easy when we provide only the distribution.
Thank you for your question. And I think Dirk knows what I'm going to say. I don't like this model at all. I don't like it. No. No. I like him to say, or the other ultrasonographers like you vote here. I think it's a borderline. And this figure shows it's much better because you indeed see the difference from 6 to 26% that probably will be borderline. But if you have experts ultrasonographies, as many are here, I think telling me it's 26% borderline, 20% benign, and 80% and so on, is for me, it doesn't help me. I'm sorry. It doesn't help me. I want to know what you as expert think it is. And then I will take, because I as a gynecologic oncologist, I'm not an expert sonography. I have to rely on your opinion, what you think it is. But probably for people who are less experienced, this model helps a lot. So to answer your question, I think this is more informative because then I indirectly can see what it's most probable.
So then, above the risk percentages, we have the relative risk, so the increase in this particular patient. But I agree that we try to be specific if we can, but very often we fail and we don't want to disappoint, and at least then we can give some figures based on an objective model. Because not always we can give a precise, specific diagnosis, whatever we try to do. And with more experience, we will be better, but we will never be perfect. And this model will help many people to come easily to a much higher quality. And then we have to discuss what to do with the result. And then I think, again, we need to sit together with the clinicians to discuss from which risk onwards we refer the patient to the gynae-oncologist. And then the gynae-oncologist can decide if the risk, for example, metastatic tumor is above X, I will do mammography, colonoscopy, and other investigations to rule out a primary tumor which is elsewhere, which is not ovarian cancer. And if it's a borderline, if the chance of a borderline is high, then he can discuss fertility-sparing surgery with the patient and leave the ovary and do cystectomy. I'm not sure.
I think this is a prime example of where the odds ratio would be helpful. I think that would be, you should have that given all the time, really, because that gives extra information, extra value to the assessment.
Yes, I agree, but your left column will be different, and Ben will tell us the left column is the average of all IOTA patients. So if you're working in a regional hospital, your left column will be much more green than if you're working in the center with Daniela in Prague. Then your left column, there will be little green. You see, so the prior risk of the patient entering your unit is different. This is the average for all IOTA patients. So we might need to adjust this to the type of center you're working in. But your comment is perfectly...
I think it would be better if the left column includes already other characteristics without the ultrasound, the age, the CA125, and so on. And then if you add the ultrasound, then you see the difference. That would be helpful.
Very good option, thank you.
Can go on. Second image. This is a multilocular solid cyst. It's easy also with easy descriptors to identify it, I think. We have color Doppler. Here it looks more or less moderate, but if we look at the 3D power Doppler, we can see that it's highly vascularized. And let's apply the rules. The age was 36, so 37. Oncological center, yes. Diameter, 74. The maximum diameter of the largest solid portion, 38. No more than 10 locules. Population, no. Acoustic shadow, no. Ascites, no. CA125, 2, and 258. We calculate, and here was the result. According to what Nexa, it looked like malignant disease and probably invasive disease, late stage. And it was quite easy. It was a 3C endometrioid ovarian cancer. Another one, sorry, in this case I have the 4 images. So this is quite easy. This is a unilocular cyst with almost, I wasn't able to define if ground glass or low level. It's more than low level, a little less than ground glass, but probably ground glass. And also I was not sure if this was a little solid portion or just debris. But also this portion, there were no color Doppler. The patient was 66, she was asymptomatic. Let's apply the rules. 66 age, diameter 115 millimeter, no solid portion, more than 10 locules, no. Population, I say known, because I was not sure that was population. Acoustic shadow, no. Ascites, no. Biomarker, 11.
I have one comment. We say always go for the worst case scenario. If you're in doubt whether there's a population, yes or no, then I would say yes. So I prefer to go for worst case scenario.
Okay, okay.
But this depends
anyway,
about
the
your
result was the same.
level of certainty.
We calculate, and it's quite clear, the definition from Nexa that defines this mass as benign, as I think all of you Thanks about that. And it was a serous cystadenofibroma,
Which is benign.
SB9.
Okay.
Yeah. Next case, let's see the clip. This is a solid mass with some cyst inside, with some fluids also. And there are shadows also. Who thinks it's benign? Who thinks it's borderline? Who thinks it's malignant
It's possible.
or benign? Okay.
Difficult case.
No vascularization, just color score 2 I gave. Just very few spots of vessels. And here is the adnex model, 56-year, diameter 124 millimeter. The solid portion was the same, of course. No locus, no population, acoustic shadows, yeah. Ascites, well, probably a little, yes, because it was outside of the pelvis. It was a very small amount. Well, CA125 was negative. Sorry, it's not evident. Calculation. Well, it looks like a malignant disease in adnex model, probably because of the solid portion so big. And even if I didn't put that there was ascites, even if in a small amount, and even if CA125 was low level. But this happens also in the daily practice, that sometimes models do not work so well. But you have elements to judge for this mass because it was mobile, regular margins, cone shadows, just a color score of 2, so it was easy to perform a diagnosis in this case because it wasn't just an ovarian fibroma. It was very big, but it was just an ovarian fibroma.
Okay. We have false positives, we know.
We have false
We have false
positives,
negatives,
but,
we know.
I decided to bring some cases very
But it's
contradictory,
good.
sorry. Okay, the next case,
Yes.
we have time
Yes,
to
please.
go on?
Sorry to interrupt you, but just to give us an example, in your future day life, if you want to suggest to use adnex, would you like to tell us your future report? I mean, first you will say, according to my subjective evaluation, it can be an ovarian fibroma. And then how do you continue? But if you look at my graph, there is a suspicion, but how can we use it?
Well, I think subjective assessment, if you're confident, overrules everything. And that's what we said before. Why use a model if you're certain? If you say this is an ovarian fibroma, why would you use a model? If you say this is certainly benign, don't use a model. So that's what we came to, the practical application of simple rules, of models. I think if you're certain this is benign or this is malignant, act upon this. But if you want help from a model, then you can use a model. And then you can say, what I write very often is, I think it's this, but I cannot exclude the presence of malignancy. And if your model tells you, well, there's a 50% risk of malignancy, then I would certainly say, if I had the result, beware, because the model predicts that there is a good chance of a malignancy, 50%. And the model is well calibrated, as we've seen yesterday, so this means that this is a real risk. If you have 100 patients with this profile, 50 will have a malignant tumor.
Yes, but the problem is that those who have less experience, who do not recognize this as an ovarian fibroma, will have much more patients where they are directed in the wrong way. So I think the subjective assessments and experience remains the most important, and that the adnex model and also the simple rules are adding, but that you should take into account that what the number of patients that you say I'm unsure is much lower than in many centers with less experience, and then see what the adnext model or the simple rules adds. Did you do an analysis in small centers?
Yes, in IOTA examiners who were experienced, the number of uncertain cases was 8%. And that means uncertain, benign, or malignant. Specific diagnosis is higher, that you cannot give a specific diagnosis, that you say, I think it's benign or I think it's malignant, but that you cannot say this is a dermoid, this is a fibroma. If you look at less experienced examiners, then they cannot give a diagnosis in almost 50% of cases. So experience will help you to become more confident about a specific diagnosis. And I think the lecture by Professor Valentin and Zanoni this morning was really instrumental. The more lectures you see like this, the more you will say, this is probably granulosa cell tumor. But then again, we need to be careful not to overdiagnose and not to be too confident, and we cannot replace the pathologist. So in the end, it's always about optimal referral to an oncologist or to a general surgeon, or not to operate. So I think this is the main decision we have to make, and not try to replace the pathologist.
I think the one thing you haven't commented on, though, is it is the relationship on a personal level often between the, some places you scan and operate, but between someone who has established that track record effectively of getting it right, between someone who's going to be doing the operations and someone who's actually doing the imaging. And it's those close relationships between imaging people and surgeons that actually leads to trust and actually going on the subjective impression. I think that makes an enormous difference. It's not just about the numbers and everything, it's about individual good working relationships within units.